were also some posters that looked at MCED testing in the diagnostic pathway and not just using it as its intended use currently for screening the asymptomatic individual. These posters were looking at patients with signs and symptoms preceding diagnosis and possibly how MCEDs could help speed up the diagnostic pathway. Can you tell us more about what these posters told us?
The Simplify results presented at ASCO have been anticipated. This was a large-scale observational prospective cohort study, multi-cancer early detection test in symptomatic patients referred for cancer investigation. This found that about 6.7% of the patients were diagnosed with cancer through the standard of care. MCED detected cancer in 223 of 244. A positive predictive value of 75% and a negative predictive value of 97.6%. The sensitivity was lower in earlier stage cancers, higher in more advanced cancers, increased with age and later stages, I mentioned. The cancer signal origin or tissue of origin was accurately identified in 85%. What this tells us is that this is a proof of principle, really, that these tests, and this one in particular, could identify cancer in patients who were referred for cancer workup. That's the most we can take away from this test right now, or this study. There were two other papers that looked at patients with signs and symptoms preceding cancer. They were symptomatic, and they looked at how MCEDs could potentially be used to speed up diagnosis. The first was at NCCN. This was a large number of patients, over 100,000. The bottom line is that, again, this is a tool that is confirmatory, if anything, that patients with symptomatic cancer are able to be identified in addition to traditional workups with MCED testing. I don't think we can, again, take more away from this study other than that this tool is complementary, but certainly not replacing, and I'm not sure it clinically changes the lead time to a diagnosis, at least at this point in time. There was another study that was very similar. It was retrospective observational cohort study. The median time to cancer after being referred was greater than 5 weeks. The takeaway was that there is a need for more tools for multi-cancer detection tests that could aid in the detection of multiple cancers and faster diagnostic resolution. But will that lead to clinically meaningful differences? I don't think that poster was designed, or that study was designed to sort that out, but it is additional information that I think will help refine the test going forward. What is your takeaway, as you're in the primary care setting? How do you think these tests, these MCEDs, could be incorporated into primary care?
Thank you, Dr. Schram. That's a great question. We're at the forefront, the cutting edge of some great new innovations out there for early cancer detection. We only currently have 5 cancers that we can screen for, but that only accounts for 25% of cancer deaths within the United States. And so there's a huge unmet need for us to do something differently, or, integrating something different or a new test that would help us for that early cancer detection. These last 2 posters that you were discussing, I think it really speaks to the possible versatility of this liquid-based testing, or these MCED tests, to not only live in a space where we are screening the unaffected patient, but it can also be utilized and has the potential to be adjusted, the platform to be adjusted and actually be utilized in potentially the symptomatic patient as well, or even in the minimal residual disease space.